All right. Good afternoon, everyone, or morning, depending on your time zone, and welcome to today's webinar entitled Evaluation and Management Coding Changes for 2021. We know it's an unprecedented time right now, and especially in our industry. So we thank you for taking time out of your busy schedules to join us for this 60-minute web session. Before we begin, let's cover a few housekeeping items. All attendees have been placed on mute in order to eliminate background noise. We encourage you to interact with our speaker throughout the presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. Although we may not get to all of your questions live today, we will be providing you with an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented, a link to the live recording, and information on how to obtain your CEU within 5 business days. May I reiterate, you will be receiving an email with a link to the FAQ document, a PowerPoint that's presented today, a live recording that we've recorded for today's session, and information on how to obtain your CEU within 5 business days. Today's presenter is Ardith Campbell, Content Product Manager here at Vitalware. Ardith, the show is yours. Do you now have the floor?
All right, thank you, and appreciate everybody taking their time. And not only are there the changes going on with the pandemic now, but we also have a lot of changes coming up in the E&M coding section for 2021. And so I do want to put out our disclaimer that this is information that's correct as of today. If there are changes made through the proposed rulemaking, of course it won't be in here. But I do want to state that the AMA has their education hub, at keeping that updated, and a lot of information is out there for you. So our objectives today is just to kind of take a look at the rationale behind the changes, the criteria for code selection, and then I've got a few samples that we'll take a look at about coding. And really our agenda is, why are they changing now? We'll take a look at the code revisions, and along with that goes some revisions for the guidelines and a bunch of definitions. And the AMA was very great at putting in the definitions for different things so that everybody can be on the same page. And those definitions will be going into the code books, and that kind of goes into the rationale to help streamline things and also to reduce audits as well. So we'll take a look at the table of risk that is going to be used for the medical decision making. And then our coding scenarios, and then a checklist for readiness. So we do have a lot of information on the slides, and I'm not going to read everything or go over every point, but you will have the information to take with you and study. Now, this is only going to apply to your current procedural terminology codes in that 99201 through the 99215 range. And so that's your office visits and some of the prolonged services that go along with the office visits. So it's just that one specific range, and the AMA is going to continue to go by section. So, as part of this, I'll get to the nursing home and domiciliary visits, preventive, etc. And at this time, there's no estimate when that section is going to be completed. And there's no change for the facilities for their Medicare claims, where you report the G code instead of the E&M visits. And the facilities, you still will continue to use your own E&M guidelines for code selection. So this is mainly for the physician side, but it's also important for everybody to kind of have a working knowledge of this. So why are they changing now? This is probably the largest change in 30 years. And really, this is part of the patients over paperwork initiative. And they want to cut through the red tape and to reduce some of the burdensome regulations. And this is also to help the physicians with their burnout. You know, let the providers see their patients. That's what they want to do. So in 2019, CMS was going to release some HCPCS codes, and that was kind of going to be a headache because you would have dual systems, one for Medicare patients and one for everybody else. So the AMA stepped in and said, hey, let us take over and do this, and then there'd be one code set, hopefully, for everybody. And so where they have gone and taken a look at this is that because there was the templates where you had to have your review of systems and all of that fun stuff, it was making there was too much text within the notes. So, they call it note bloat. And it was making things downstream for providers that saw the patient, several months or years down the road, to have to wade through a bunch of stuff that really wasn't valid. So the big changes are that the big criteria for code selection is going to be based on medical decision making or total time, and the history and physical is not going to be part of the elements for code selection. So the timing, context, all of that is going to go away, but just for the 9920, the 992 codes. But don't throw away your 95 and 97 documentation guidelines yet, because you will still need them for your other E&M visits. So there are going to be revisions to the code descriptions and to the medical decision-making portion. Also new guidelines, especially for using the time. Most of the time range is very specific in the new E&M code descriptions. And so you won't have to have that kind of mid-range code time to bump up on most of the codes. And of course, there are some exceptions. And then another exception that's going to take a little bit longer is for your emergency department levels, and that's due to the intensity of the services. And so there are new definitions in the MDM, the prolonged services codes. There are some already existing codes, so they will be tweaked a little bit. And then there are some new prolonged services codes that are going to be coming out. All right, and time can be the only component used for code selection, with the exception of the 99211 or your nurse visit. And what's going to be nice is that counseling and coordination of care does not have to dominate the visit if you're going to use time. So where it used to be, 50% of the time had to be counseling or coordination of care, that part is gone. And so because the different categories use time differently, when the other sections are reviewed, you're going to need to be able to review the guidelines for each one, because they're finding that time is different for those nursing home visits versus, your home or domiciliary. And so they are having work groups around each of those so that they get a really good sense of what's going on. All right, so expect a whole bunch of changes, but they'll be nice. So they must have a face-to-face service with a physician or your qualified healthcare provider, and that's going to be like your nurse practitioners, physician assistants, for those things. So the clinical staff that are supervised by your physician or your QHPs may use the 99211. I have not seen any updates to any shared visit or split visit regulations. I have not seen anything on changing teaching physician rules. And so I don't know if there will be updates to that. And so we'll need to keep an eye out for those. And then the prolonged time will still be reported with add-on codes. But there are going to be some differences in the code changes. So for the total time on the date of the encounter, that is going to be part of, this will be part of the new definitions. And notice that the instructions state that this includes both the face-to-face and non-face-to-face time. And I did change the font in that second bullet point just to kind of make that stand out a little bit. And so the time for that is that total time on the date of the encounter. And so that is personally spent by your physician or your qualified health care provider on the date of the encounter. And so, and then the parentheticals in there also state it does not include the time in the activities normally performed by clinical staff. All right, so what is included in that time that that does get counted? Well, that's the time preparing to see the patient. So if you are reviewing any tests, so you can go over those with the patient, obtaining or reviewing any separately obtained history. So that could be, you know, reading an evaluation from, you know, that the cardiologist has sent over, or if you had to get some information from the teacher at school because you're doing an attention deficit disorder review or something else. So and also referring and communicating with other healthcare professionals when that's not separately reported. So and care coordination is also included here when that's not separately reported. So I wanted to point those out specifically because you know, the AMA says do not count any minute twice. So if the provider is performing, you know, the chronic care coordination or the transitional care management, those are separately reported codes. So you would not count the time spent on those codes in with the E&M visit for today. So just kind of a little caveat on those procedures. All right, so here we have the definition for the 99211. This code is going to be deleted, and the suggested replacement code is 99202. And the reason why this is being deleted is that really the only difference between the 99201 and the 99202 is the amount of, is the medical decision making. You know, usually the 99202 would have none. And the AMA's rationale for that is you're really not going to see a new patient without some kind of medical decision making. So they really felt that there was no longer a need to have the code. And then also there was no change discussed about the code selection for a new patient versus an established patient. So the typical, you know, the normal, what you're used to, the 3 years of no professional services is still going to be in place. So here we've got the new description for the 99202. So in your 2020 description, our today's version is that, you've got your expanded focused history and expanded problem focused examination, straightforward medical decision making, blah, 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 typically 20 minutes. Okay, the new revised version is going to be, it's your office or other outpatient visit for the evaluation, blah, blah, blah. And it says a medically appropriate history and or examination and straightforward medical decision making. So when using time for the code selection, 15 to 20 minutes of total time is spent on the date of the encounter. So it's being much more succinct, and not every patient is going to need a hands-on exam. And so if you don't need one, you don't have to do one. But if you do need to do one, do what you need to do to take care of your patient. And with the range of time within the code, the AMA is very specific in saying, as long as you're within that range, you pick that code. Now for the 99203, here you can see that, it's saying it's, straightforward medical decision making. And then if you're using time for that code selection, it is 30 to 44 minutes. And so I'm just going to go ahead and hit the 99205 because it's pretty much the same thing over again, just it's changing the amount of time. For the 99205, if you're using time, it's 60 to 74 minutes total time spent on the date. But for services that are 75 minutes or longer, there is a new prolonged services code that can be used by the physician. That specific number is not available yet. That's why there are the 3 X's. So expect that one. For this prolonged service, the physician, if it's physician, the physician doing the service, there's one that they have available that will be for 15-minute increments. So but they still have some of the older codes, so we'll get there. Now for the 99211, the change is basically the last sentence where it says typically 5 minutes are spent. That piece is gone, and this would be something that this might not need a physician or your qualified healthcare professional. So this basically is still your nurse visit. And then again, here with your 99212, the total time spent for this code is 10 minutes to 19 minutes. So really the only huge difference on this is the time. And let me go ahead and go to the 99215. And so this one is the time is 40 to 54 minutes. So a little bit shorter than the other, the new patient. But once you hit that 55-minute mark, there is that, there will be a new code for prolonged services. All right. So services that are reported separately, that can have a different procedure code would be, if the if the doctor also does the ultrasound and does the interpretation and report separately, and also if you have another procedure on that same day, like a skin tag removal or a mole removal, the modifier usage is going to remain the same. So you would have your modifier 25 for the, your separately identifiable service. So that piece is remaining the same. All right, so here we've got the 99358 and the 99359, and this is the prolonged evaluation in management service before or after direct patient care. And so this is still going to be the spot where you have for the first hour and then each additional minute. So it is one of the differences where we would still have that, you would have to get to the minute 31 to be able to report the 99358. And what is really nice for the physician side is that there are some codes for clinical staff services where the physician or your qualified healthcare professional is supervising. There's a 99415 and a 99416. And so the 415 is for the first hour, and then the 16 is for each additional hour. And these can be used in conjunction with your E&M codes. And this could be an instance where someone maybe has taken a medication and needs to be, wait there in the physician's office just to make sure everything's going okay. Or sometimes if they're having a nebulizer treatment in the office or there's something going on where the nurse or someone needs to go in and monitor the patient a bit more often than what would be a normal visit. It could also be, for example, if somebody has diabetes and they need to have the nurse come in and do some training on how to do their insulin injections or how to do their glucose meter, those kinds of situations. So kind of think how this would work in the physician's office. And unfortunately, within the guidelines, it is stating that it's not available for facilities to use. And then this is just kind of the second page with some of the parenthetical notes so that you have those available just to look over. Okay, and so the new prolonged service code, this is going to be with or without direct patient contact on the date of an office or other outpatient service. So it's kind of, this is the new one that for the physician to use or the qualified healthcare provider for each 15 minutes. And one of the requirements is that this can be used when the office visit was time-based for that code selection. So if you have someone who might be a worried well person that came in and has a ton of questions and is taking a longer amount of time, and of course it's usually going to be when you're reporting it with the 99215 because of that time element. Or it could be used, if someone has, a cancer diagnosis and the family comes in and they're asking a lot of questions and wanting to know, what can we do to, what are the treatment options and all of those things. We had my mom unfortunately was diagnosed with pancreatic cancer and passed away, but we went with her to a couple of visits to the oncologist, and we had a ton of questions for the physician, and he was very gracious to go through and answer our questions. And this is an instance where time would be used as for reporting those services. And or you have a patient that's been trying to self-diagnose and has a list of questions to ask the doctor because Google said they needed to ask all these questions. And so sometimes taking care of your patient does take a little bit extra time. All right. So we took a look at the code, so let's take a look at the guidelines. And so for the history or exam, it can include your medically appropriate history or physical exam when performed. And the emphasis on that is mine, because it doesn't always take that hands-on. You don't always have to have a hands-on review of systems, but just you do what is needed for the care of your patient. So another big change is this second bullet point, and I think it really is fairly important. The extent of the history and exam is not an element in the code selection. So the nature and the extent is going to be determined by that treating physician or the non-physician practitioner that's reporting the service. Now the care team can collect the information, and also your patient, the patient can provide information, or their caregiver, and that can be through a portal or a questionnaire. So it's, how are you feeling today? Check where you're having issues on the little box. And so but that information that's provided has to be reviewed by the physician or qualified health professional. So the definition of the number and complexity addressed, and there are a lot of different items here. So, multiple new or established conditions can be addressed at the same time, and that may or may not affect the medical decision making. And so it could be that the symptoms are kind of clumped, towards a specific diagnosis, but not necessarily, because each symptom is not necessarily a unique condition. And any comorbidities or underlying diseases are not considered in selecting the E&M level unless those comorbidities or those underlying diseases increase the amount or complexity of the data that's to be reviewed or analyzed, or there's an increase of the risk of complications or morbidity or mortality of the patient's care management due to that condition. So just because multiple problems of a lower severity may create a higher risk due to interaction. So it just is really dependent on the patient and what is being treated for the day. So it's so there are still many variables, but this does provide kind of a guideline of regarding the number and complexity of the problems addressed. All right, and all of these items are going to be in the definitions. So the problem, it's that your disease, your condition, illness, or injury that is being addressed at the encounter. So your problem addressed. A problem is addressed or managed when it's evaluated or treated at the encounter by the physician or qualified healthcare professional. And there's examples that they're giving about the problems that are addressed. And also the checking the clinical decision support mechanism for the appropriate use criteria is also added into this, into that as a kind of as a note so that it can be counted. And so here they've got definitions for a minimal problem. So it may not even require the presence of the physician, but it's provided under your doctor's or qualified healthcare professional supervision, self-limited or minor. So it's, you know, that's something that's going to run a definite and prescribed course, and it's not likely to permanently alter health status. So we've got your a stable chronic illness. So that's something that's going to last at least a year or until the patient passes away. And so again, more definition. And so down near the bottom of the slide, the bold for on without is from the AMA. I did not add that bold, but it's saying that the risk of morbidity without treatment is significant. So, and then the examples they give are your well-controlled hypertension, non-insulin dependent diabetes, and those types of things. So they're really kind of helping to spell out for everyone what a stable chronic illness includes. And then you have your acute uncomplicated illness or injury. So it's a recent or short-term problem with a low risk of morbidity. Again, the examples given here, you know, cystitis, allergic rhinitis, or a simple sprain. And then chronic illness with exacerbation. And so this one that is a chronic illness, it's getting worse, or it's poorly controlled, but part of the medical decision making for that is not going to require considering a hospital level of care. And that is kind of, and then that leads us to our undiagnosed new problem with an uncertain prognosis. And that's going to be something that has differential diagnoses. And it's going to represent a condition that will likely result in a high risk of morbidity without treatment. And the example given here is a lump in the breast. All right, so we have an acute illness with systemic symptoms, and that is going to be an illness that causes systemic symptoms and has a high risk of morbidity without treatment. And so that's going to be, well, I would put our coronavirus in here. So it's general symptoms like fever, body aches, or fatigue in a minor illness, but might be have some other issues along with it. So the systemic symptoms may not be general, but they may be a single system, and they've got, you know, your pyelonephritis, colitis. And then we have an acute complicated injury, and that is going to be an injury that requires some treatment that includes the evaluation of body systems that may not be directly a part of the injured organ. And this is, you know, an example here would be a head injury with a brief loss of consciousness. All right, so here we've got more definitions, and I'm just going to go ahead and just say, you know, for these, you have your acute or chronic illness that poses a threat to life or bodily function. CMS or the AMA wanted to make sure that we had those distinctions out there because this will play a part in the medical decision making. So having these specific definitions written down provides guidance for everybody. All right, so a test, and that's imaging laboratory tests, and they are stating that a clinical laboratory panel like your basic metabolic panel is considered a single test, because that goes into some of the counting of elements that we get to do. So, so let's see. Ones that I find interesting, that I think is a great example of having these written, some of these definitions written down, is the independent historian. And so this could be an individual, and they are stating, it's a parent, a guardian, surrogate, spouse, witness, who provides a history in addition to any history that might be provided by the patient. But if the patient's not able to provide that history, this would be, the mom or dad that is bringing their child in that, could be 18 months, and so it doesn't have much speech. It could also include the paramedics if they're bringing somebody in by ambulance, caregivers, and what have you. Now, the appropriate source, that is going to go into the discussion of management data element. And so this also includes, people involved in the management of the patient, but may not necessarily be a healthcare person. So we'll be able to see that when we take a look at the medical decision-making tool. So, and here we've got risk, the probability and or consequences of an event. And so it's, we have your high, medium, and low. Kind of in the middle there, it says that, trained clinicians apply common language, meanings to terms such as high, medium, and low, or minimal, and do not require quantification for those definitions. So, but that quantification might be provided when evidence-based medicine has those established probabilities. So, so they have that defined. So what will be nice is you'll be able to take that and use that if the medical record's being audited. Then, the audit person will be saying, well, why this? And you'll be able to point to some of the definitions. So that's great. And your morbidity and the social determinants of health. So any economic and social conditions that could influence the health, and that might include food or housing insecurity, lots of other stuff. Now, the drug therapy requiring intensive monitoring for toxicity has a really nice long description here. And this is not something like your the patient on insulin. I did not bold that bottom portion. That was done by the AMA. And so anything that's really really toxic, that you need to really watch the patient and have lab tests within a specific time frame, that's what is meant by these. So the the monitoring glucose level for an insulin dependent person is not included, or the annual electrolytes or renal function for a patient on a diuretic, because it does not meet the frequency threshold that is listed there in that definition. All right, so the code selection, of course, is going to be based on the level of medical decision-making that's defined for each service, or the total time for the services performed. So the decision-making has 3 elements. So the number of and complexity of problems addressed, the amount or complexity of data to be reviewed and analyzed, and then the risk of complications. So then you would select the levels of straightforward, low, moderate, or high. And there is no medical decision making for 99211. And then shared medical decision making is involves the patient or their family preferences, the education, and explaining the risks and treatment options. And that can also, your medical decision making can also be influenced by the role and management responsibility. And what that means is that, if you have a patient who's living alone without much of a support system, the physician and the patient are going to have to take that into consideration when discussing some treatment options, or if they have a splendid support system, or if but if they have an 85-year-old husband who's taking care of his 83-year-old wife, or the 83-year-old husband taking care of his 85-year-old wife, there's some other factors that are influenced when they're talking about that decision making. So the amount of complexity of data, that's going to include your medical records and tests, and other information that has to be, maintained, ordered, reviewed, and it can come from multiple sources, and also from interpersonal communications that are not necessarily separately reported. And ordering a test is going to be included in the category of test results, and the review of the result is part of the encounter. And then your amount of complexity of data is going to be divided into 3 categories, and that is your tests, documents, orders, or independent historians, and each unique item can be counted until the specific threshold is reached. The other category is the independent interpretation of tests, and then the third is that discussion of the management or interpretation with an external physician, qualified health professional, or appropriate source. And the appropriate source, remember we discussed earlier, was someone that may not be a healthcare professional, but still had part of the care of the patient. And I think they had lawyer, parole officer, and other things listed there too. So, all right, so our risk of complications, and that is going to be the morbidity or mortality of the patient management decisions that are made at the visit and that are associated with the patient's problems. So, for example, if a decision is being made about hospitalization and includes the consideration of different levels of care, do they need to be inpatient? Can it be outpatient? Same-day surgery. Now, there's also an example here where they're stating that, you have a psychiatric patient with a lot of support, so they can determine, well, they can do well in an outpatient setting, or is this someone that maybe needs to be inpatient? So there's nice amount of definitions. So let's move on to the table of medical decision making, and this was based on the table of risk. So when you take a look at it, you'll actually kind of almost understand where it came from. And so it's used as your guide in your code selection. So there's 4 levels of your the 4 levels, so low, straightforward, high, with 3 elements, and then the risk of complications. So you have to meet meet or exceed 2 of 3 levels. So with that being said, let me pop up the table of risk, and the AMA does have this out on their website in their hub. So let me kind of highlight this. So on the far left side, they've got the code. Now your level of medical decision making is going to be, your straightforward, low, moderate, high. So your number and complexity of problems addressed. So if it's low, it's your 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. So that would be low, your number and complexity of problems addressed. All right, so when you get down to moderate, you can see there's 1 or more chronic illness with exacerbation, progression, or side effects of treatment, or you have 2 or more stable chronic illnesses, or you have 1 undiagnosed new problem with an uncertain prognosis, or 1 acute illness with systemic symptoms, or 1 acute complicated injury. All right, so the elements of medical decision making, if you're going with the straightforward, the 99212, you have minimal or none. But when you hit down to the limited, and this is where you have to meet the requirements of at least 1 out of the 2 categories. So category 1, your tests and documents, you have to have any 2 of the following. So a review of a prior external note from each unique source. So if you have 2 unique sources, that you've got your 2. Or you have a review of the results of each unique test. So if you have, your basic metabolic panel, and then also your A1C results, you've got your 2 unique tests. Or you're ordering unique tests. And so that could be, CAT scan, ultrasound, lab tests. If you are reviewing the results of previous labs, and then you decide you need to order another test, there's your 2. And then, or you have your category 2, and that is an assessment requiring an independent historian. So as you go down to the different elements and the amount of complexity of data, you can see that it gets larger as you get into the more complicated, higher risk types of edits. So it's really nice that they've got this all spelled out. Now, your risk of complications or morbidity or mortality of patient management, if we're taking a look at the moderate risk, so the moderate risk of morbidity from additional diagnostic testing or treatment, this is, prescription drug management, and this list is not meant to be exhaustive. But to give you an idea of what is considered moderate. So you have a decision regarding a minor surgery with the patient or procedure risk factors. If you're sending somebody over and they have shellfish allergy, or they have your diagnosis or your treatment is significantly limited by social determinants. So that would be, you know, something is going on within their home life, and it could be that you know, if someone lives you know, in an inner city and they have difficulty getting to a grocery store and having difficulty getting access to fresh fruits and vegetables, and so they're relying on a lot of canned goods for their veggies, that can contribute to their high blood pressure because of the additional sodium. And if they're on high blood pressure meds, that can be another risk. And so the high risk of morbidity from down here in the bottom right-hand corner. So this is going to be those items that, you know, you're regarding, you know, decision made regarding elective major surgery, you know, a decision regarding emergency major surgery or hospitalization, or a decision to not resuscitate or to de-escalate because of poor prognosis. So you would need to meet, you know, 2 out of 3. So for moderate, you know, you would have, let's say the patient has 2 or more stable chronic illnesses. You know, we could say they have high blood pressure and high cholesterol. And then the physician is reviewing the lab results for their cholesterolemia. And I'm thinking of the diagnosis codes instead of the procedure codes, sorry. And so they, you know, before the patient came in, they were to have labs done. So they had their cholesterol checked, and also, oh goodness, you know, and they had another lab test done. And then, well, or you reviewed the lab test and then you ordered the blood work for them to have done prior to their next, you know, their next scheduled visit. Well, you've got 2 out of 2 there, or 2 out of your 3. So you've got moderate out of both of those. So just, you know, take a look at those and just kind of get comfortable with them. The AMA also had a pre-recorded webinar that went over a little tool that they have that will have check boxes, and we'll also make sure that we send out this PDF when the slides go out so that you have an idea of what is, so you have it with you so you can take a look at it and use the information. All right, so, uh-oh, I gotta hurry. Okay, so let's say you have a 35-year-old female established patient that comes in with a follow-up of her stable type 1 diabetes. So there's a medically appropriate history and physical, and says that the visit meets a low level of medical decision making. And then this one would be a 99213, and this is one example that's given at by the AMA. All right, now let's say that we have a 75-year-old female, that established patient that comes in for the follow-up of her stable type 2 diabetes, and that's currently treated with glucagon. During the review of the A1C results and a review of her last 3 months of her daily glucometer results, the patient's diabetes has not been stable. And so they spend a lot of time reviewing her eating habits and treatment options, and then she is placed on insulin injection. and the total time spent was 45 minutes. And for this one, it's the 99215, and this could be coded due to time. All right. And so here we've got a 55-year-old male that's coming in just for a blood pressure check due to recently diagnosed high blood pressure. So the nurse assesses the patient's weight and blood pressure, and time spent 5 minutes. I just put that in there. It really doesn't mean anything, but it's a 99211 for the nurse visit. All right, and then you know, you have your 15-month-old male presenting because the parent is stating that he's been tugging at his ear for the past 3 days. Doesn't seem to be in acute distress until last night, when he cried every time they put him down to sleep. You know, ear infection. And so for this one, it's 99213. And then the last one is kind of a little funny one. You have a 2-year-old female who wouldn't tell mom why she needed to go to the doctor, but was very insistent upon seeing the doctor. And upon questioning, she tells the doctor that there's a problem with her bottom. It has a hole in it. And then the doctor gently explains that everybody has one and everything's okay. Time spent is 10 minutes. And I put that as a 99212. And that was my poor niece. She did that when she was real little, so we still all chuckle about it. But I wanted to make sure that we kind of went out with a little high note. But just to, you know, make sure, are you ready? Identify a project lead. The AMA says 3 months is probably not going to be sufficient to get everything ready. So, you know, make sure you're preparing how to code with these new items. Check your protocols to see if anything needs to be updated. And since there is not a specific requirement at this time having specific start and stop times, you know, how are you going to capture the time? Because somebody, of course, might be upset that, you know, well, I didn't spend 30 minutes with the doctor. And so just to kind of keep that in mind, you know, check with your compliance plan to see if there's anything that needs updated. Also your EHR vendor, you know, do they have anything that will need to be addressed? And then also make sure that there might be any payer or medical liability coverage requirements as well. So sorry for being so wordy, but hopefully you'll be able to review the recording again. And you know, we did go through all of that. And the last page is references. And so just, you know, please be sure to visit the AMA hub there. It has a lot of information. And how are we doing on time for questions, Julie?
Well, because of everyone's full plates, we're going to be very sensitive to time, again, especially right now. So we're going to go ahead and wrap this up. We did receive several questions, and we thank you so much for engaging in this presentation and submitting your questions. Have no fear, we will pull all of the questions that were sent in throughout today's session, and we will create an FAQ document with all the questions asked and then the answers to each of those. An email, again, will be sent out within 5 business days with the FAQ document with all the questions and answers, a copy of the presentation, a link to the live recording, and information on how to obtain your CEU. So make sure you keep an eye out for that. Again, that will be an email sent to you within 5 business days. Thank you again so much, both Ardith, for all of your intelligence. Again, you always amaze me with all of this information, and thank you everyone for joining us today. We know, again, your plates are so full, and we're going through an unprecedented time right now. So we wish you all the best. Stay healthy and have a great rest of your afternoon. Thank you, everyone.
Thank
Bye-bye.
you. Bye-bye.